So I did mention the 5 standard views, which we're going to go into detail. We'll start off with the parasternal long axis view, and we're going to work our way down to each of these 5 views. So for the parasternal long axis view, where do you want to start? So a couple things. We start at the 3rd or 4th intercostal space, as you can see in this diagram, and you see this green dot. That green dot is going to be the notch. And where is that notch going to be pointed? It's going to be pointed here to the right shoulder. And this is going to be kind of unique. Most of the views of the heart, the notch, the dot's going to be pointed to the left shoulder. But in this case, it's going to be pointed to the right shoulder. And you want to try to mimic the view you see right here. So why do we look at these books? Why do we look at these images? Because you want to try to get the exact same view if possible to identify the different structures. And it's always good to be redundant, talk about the structures, what are you looking at as much as possible, always identify them. So when we talk about this parasternal long axis view, this is going to be a cartoon of what it looks like. Here's your left atrium, here's the left ventricle, here's the intraventricular septum, here's the right ventricle, and here's our left ventricular outflow tract, and here's going to be the mitral valve, there's going to be the aortic valve. The mitral valve will always have 2, when we talk about, it's going to have the anterior and posterior leaflets. When we think about it, the anterior leaflet's always going to be closest to the aorta. I always think about A and A. And posterior leaflet, it's going to be over here that you can see with when we talk about the pointer. I think the parasternal long axis view is the classic view when you're doing cardiology questions. They want to explain the physiology of HOCM, hypertrophic obstructive cardiomyopathy. This is a great view they always show where you can really see the septum being very hypertrophied in certain cases. So you should be very familiar with this view and match up these anatomical locations with what you see on the ultrasound. So let's go through it together. So this is going to be your left atrium, left ventricle. Here's going to be the mitral valve. Here's going to be the intraventricular septum. Here's going to be the right ventricle. So let's do some motion here. So when we talk about this, that this is going to be a nice shot of the mitral valve over here. This is going to be the anterior leaflet on the top, closest to the aorta. Here's the posterior leaflet down here. Here's going to be the left ventricle on this side. You can see the left atrium over here. The right ventricle can't be seen as well, but I can see the intraventricular septum really well. And here's going to be the aortic valve. When we talk about the parasternal long axis view, why do we use it? Well, it's going to give you the gross LV size. How's the left ventricle functioning? It's a good view to look for pericardial effusions. It gives you a nice estimate of the right ventricle size, and you can visually inspect the mitral valve and the aortic valve, like I pointed out. So since you are already at the parasternal long axis view, what should you do is rotate. And that's why I put right here, rotate your probe. You're not going to move it. You're going to rotate it now. When you look at the notch, the dot, it's going to be pointed where? To the left shoulder. And when you rotate the probe, and you're going to do that, 90 to 90 degrees, you'll get this cartoon view over here. And when we look at this view, you're going to see the right ventricle with a thin wall, the left ventricle with a thick wall. You can see the papillary muscles over here. So this is the view that you want to get. And when we talk about the parasternal short axis view, you definitely want to, whether you're going to be tilting or fanning, to kind of start off at the apical level and work your way down to look at the mitral valve itself. So you'll see the apical level, then you'll see the papillary muscles, then you'll see the mitral valve. And I'll show you actual pictures to show you what I mean once you're in that parasternal short axis view and how you could kind of fan or tilt to find these specific views right here. So we're looking at the parasternal short axis views, looking at the apex. So this is going to be this view over here at the apical level. Now we're looking at the papillary muscles. You can see it on both sides. So where are we right here? We're just right here, looking at those papillary muscles. And then the last thing I'm going to see is going to be here when I talk about that nice fish mouth view, looking at the mitral valve, looking at the anterior and posterior leaflets, and it literally does look like a fish that's blowing bubbles on me almost. So this is going to be the parasternal short axis view. And once again, showing you what we did with the probe. We start off at the apex. Notice how it's going to be more caudal when we're pointing the probe. And as I fan it or tilt it towards the head, cephalad, I'll see papillary muscles right here in the middle. And here I would see the actual fish mouth view. And I put a still frame over here to say when you look at these papillary muscles, please don't confuse that with vegetations. I know I did one time. This patient does not have endocarditis. These are just papillary muscles. So why do we need the parasternal short axis view? Once again, it gives you a gross, estimate of how the left ventricle is functioning. You could see a pericardial effusion there. It could talk about septal kinetics. What do I mean by that? Are you volume overloaded in the right ventricle? So here's a cartoon view of the right ventricle. And if you're volume overloaded, what's going to happen is that this blue line is going to flatten. And when it flattens, it's going to give the left ventricle a D shape. So you could see a D-shaped left ventricle to say, hey, you could be volume overloaded on the right side of the heart. You could also use the four-chamber apical view, which we didn't talk about yet, to look for a bowing of the septum, also looking to see if they're fluid overloaded in the right side of the heart. And, the parasternal short axis view is also helpful for looking at volume status. And, I heard this one time that if these papillary muscles are almost touching each other, kissing papillary muscles, it may imply there's a hyperdynamic state going on in the left ventricle. So this is going to be one of my favorite views, the four-chamber apical view of the heart. And the reason why is because it's probably the only one that actually looks like the heart itself, And how do you get this view? Well, you're going to, in the perfect world, you want the patient to be on their left side down, tilt them towards you, and try to put the probe, at the apex lateral to the nipple line with the index mark around 4 o'clock. So look at the probe. This is going to be the dot, the notch. It's going to be pointing where? To that left shoulder. And hopefully you're going to get this view over here. In the cartoon, this is our left ventricle. This is our left atrium, right ventricle. You can see the mitral valve very well. You can see the tricuspid valve very well. And there's even something called a 5-chamber view. And you can see the aortic valve sometimes. But this is going to be the 4-chamber. So when we look at some of the images, that this is going to be a classic apical 4-chamber view of the heart. And you can see that this is going to be the left ventricle. Look how thick the myocardium is. This is going to be the mitral valve over here. This is going to be the left atrium. This is going to be the right atrium. And you can kind of see the right ventricle there a little bit. Here's a still view showing the left ventricle and showing its size compared to the right ventricle. You could see the septum. We talked about the D sign, that if the right ventricle is fluid overloaded, that it could have bowing of the septum into the left ventricle. The D sign specifically is for the short axis view that we talked about. Here's going to be your left atrium over here. And this is going to be your right atrium over here. And what are we going to benefit from the apical 4-chamber view? It's good to look at both the left and right ventricle, and you can see that. Here's your right ventricle and left ventricle in the cartoon. You can talk about septal kinetics, the septum referring to what divides the left and right ventricle. We mentioned already about bowing, where if you're volume overloaded on the right, you're going to bow that septum into the left ventricle. You definitely can look for a pericardial effusion. And when we look for a tricuspid regurgitation or mitral regurgitation, you could see it really nicely in the 4-chamber apical view. And you could do color flow Doppler really nicely if you want to measure that TR or MR jet. And sometimes when you're looking for the chamber apical view. You may accidentally bump into the 2-chamber view. There's nothing wrong with that. This is going to be your left ventricle, left atrium. You can see the mitral valve over here. This is just a 2-chamber view. And this is going to be a still picture just looking at the left ventricle over here. Very meaty, and you can somewhat see the left atrium down here. So now let's talk about the subcostal view. And like we said, this probably is going to be the view that you get mainly in the medical ICU. This is when someone's having a code, unfortunately. This is probably the only view you're going to get. Patient is going to be lying down. Sometimes if they're stable, we could bend their knees a little bit to try to get a view when you push down below the subxiphoid process. The transducer should be wet, aimed towards the left shoulder once again. And this is going to be a 4-chamber view. So you're going to look at the left atrium, left ventricle, right atrium, right ventricle. And this is going to be the cartoon of what we're going to see. And this is going to be a still of the subcostal view. Once again, here's going to be your left atrium, left ventricle, right atrium, right ventricle. And one last 4-chamber view. Left atrium, left ventricle, right atrium, right ventricle. And we could throw a little color Doppler on it, you know what I mean? So if I worry about, mitral regurgitation or tricuspid regurgitation, this is, if I want to measure velocity, if possible, this is going to be what it would look like. And this is going to be someone who does have a pericardial effusion. And you can see the effusion right up here. If you can see my pointer going right around there. And we saw this in a subcostal view. So why do we need the subcostal view? It's kind of like the brother or sister to the apical 4-chamber view. It helps you determine right and left ventricular function. It tells me right and left ventricular size. As you see from the previous image, you can determine if there's a pericardial effusion. And when we talk about, pulse check, during a code situation to see what the heart is doing, you could press it subxiphoid so you won't interfere with individuals doing CPR from above. And since you're already down there in the subcostal view, why not rotate the probe more, making it perpendicular and checking out the what? The IVC. And here's a little cartoon of the IVC leading into the right atrium. So when we talk about why do we want to look at the IVC, it's all about volume status. Of course, it does make a difference whether you're going to be on positive pressure ventilation or not, or breathing normally in negative pressure. But, I just want to say a couple things about how do you get the image is that, you want to use some landmarks. And one of the main landmarks when you're looking for the IVC is to measure it 2 centimeters from the entrance to the IVC going to the right atrium. So once again, the landmark to measure is 2 centimeters from the entrance of the IVC into the right atrium. And that's kind of where the hepatic vein connects into the IVC. You could use M mode to determine the diameter. And remember, we said M is for motion and measurement. So you could do the M mode there to measure it. And there's different ways to see if they're going to be, volume overloaded or if they're going to be under resuscitated. And as a rule of thumb, you definitely want to look for greater than 50% collapsibility. Here's a still. You're going to look at the right atrium, and here's going to be the IVC. Once again, look at a still over here. Looking at over here will be the right atrium, the IVC coming in. And like I said, you always put some Doppler when you're looking to look for any type of valvular abnormalities like regurgitation, to look for that flow when we talk about blood flow. And what a surprise, I put a picture of someone who had severe mitral regurgitation to kind of show, the usefulness of when we talk about using color Doppler.